Today I'm continuing with the discussion on the somatosensation, and in this I am taking up the posterior column sensations, their pathway, the processing and representation. The point comes to our mind immediately: what is special about it? Since we have seen there are what are called neo-sensation and paleo-sensations. What is the specialty of the neo-sensations? These sensations are evolutionarily newer sensations, and they are well developed in terms of the receptors, in terms of the transmitting ability. That means the fast or rapid conducting fibers carry the information. Another anatomical modification they had evolved is there is no relay in the spinal cord, but they are carried from the spinal cord as a posterior column fibers, as a fasciculus gracilis and fasciculus cuneatus, to the medulla, where they are relayed in the respective nuclei in the medulla. From there, second order neurons originate, and these second order neurons cross the opposite side here, form a ribbon-like structure ascending up to thalamus, situated medially, medial lemniscus. That is why medial lemniscal fibers. And from the thalamus, they are relayed into the cerebral cortex or the sensory cortex. That we will deal separately as the discussion continues. At each level, starting from the receptors, the spinal cord, and in the medulla, in the lemniscal fibers, the thalamus, and in the cortex, they are topographically well represented. Another important aspect about these sensations is that they require the sensory cortex for their processing and for their localizations or any attributes. Hence, without the cortex, these sensations would not exist. So they are cortically dependent. What are the various sensations carried by the posterior column? Or what are the sensations carried by the medial lemniscus? Just to name: fine touch, pressure, vibration sense, tactile localization, that is identifying the spot where it is being touched or where it is elicited, tactile discrimination, that is a 2-point discrimination, that is a tactile acuity, stereognosis, proprioception. I have put a conscious proprioception. Since proprioception can be categorized or can happen consciously and unconsciously, and processing of the unconscious proprioception is different than the conscious sensation. Therefore, the unconscious proprioception and the entire proprioception will be dealt separately to name the sensation. All the mechanosensitive sensations or mechanical sensations. This is touch, pressure, vibration, and localization, acuity, the recognitions, that is a stereognosis, and proprioception, that is a position sense. These are all carried by the posterior column. Are there any differences between these three modalities of sensations, that is a touch, pressure, and vibration? Just briefly considering them, touch sensation results from the stimulation of the tactile receptors in the skin or tissues immediately beneath the skin. Whereas the pressure sensation generally results from the deformation of the receptors located in the deeper tissues. So that means the touch sensation is more superficial. Vibration sensation, if you are looking at, this results from repetitive stimulation of the same sensory modality, also other sensory modalities. There are two components associated with the vibration sense. One, the touch, and the pressure. These two receptors are involved, hence they have a dual receptors and a dual pathway. What are the various receptors involved? Especially these are the receptors which all can carry touch sensation. I have tabulated after modifying it from a guidance textbook. As mentioned, one, Meissner's corpuscle. The type of sensations they carry is the texture, that is a sharp localization. Regarding their adaptation, they are rapidly adapting within seconds. They are carried by the A-beta fibers. A-beta fibers are a large diameter fibers. Their conduction velocity is somewhere around 70 to 80 meters per second or 50 to 70 meters per second. Meissner's corpuscles also carry the low frequency vibrations. That means they can be stimulated on the vibrations, that is the low frequency vibrations. And these receptors are located in a non-hairy skins, the fingertips, lips, etc., where there are no hairs. Then we have another receptor, what are called Merkel discs. These are expanded epithelial cells. They detect the touch as in depression or touch as in indentation. And as for their adaptability, they are slowly adapting, carried by the A-beta fibers, and they do not have that vibration mode, that is the continuous touch. They carry that information. And these Merkel discs are present in the hairy part and also on other parts. There are clusters of Merkel discs which are located in a dome or in a protruded regions of the skin. These are called ego-dome receptors. Again, it is a cluster of or a group of Merkel discs under the skin. They carry the touch and the texture. Again, these are Merkel discs, so they are slowly adapting A-beta fibers. They carry the continuous touch and they are present in the elevated and protruded regions of the skin. Maybe a tip of the finger, or maybe hypothenar eminence, or so on. Ruffini and organs or the other receptors, they carry the touch, that is a stretch. That means anything stretching, that type of a touch they carry, or anything which adds traction, also they carry the pressure. These are slowly adapting receptors. These are carried by the same group of fibers, A beta fibers, and they are continuously transmitting the impulse, and they are specially located in the giant capsules. Of course, they are located in all areas, but near the joint capsule they are located. That means they are carrying the information regarding the joint movement or joint motion, whatever. Because if there is too much stretch, they may try to assist the Golgi tendon organs to help the proprioceptive modalities. Then are a group of receptors we have been studying, that these are Pacinian corpuscles. They carry touch, transient pressure and vibration. These receptors are very rapidly adapting receptors, in the sense they adapt, or the discharges will diminish within 1/100th of a second. Whereas if you see the Meissner corpuscle, it is about second. Here 1/100th of a second, carried by the large diameter fibers, that is A beta fibers. Regarding their vibration sensitivity, they respond to high frequency vibrations, that is 60 to 300 Hertz. They are located under the skin and also in the deep tissues. So then there are other type of cutaneous receptors or touch receptors. One is a hair end organ. So these are the receptors located in and around the hair follicles. That means they are using that hair as a leverage to detect. They carry the touch as well as the movement. That means a movement, that's a movement of any part or a skin. That means some insect is creeping around. So that type of touch they will detect. Or a hair breeze, that is air is flowing very heavily, then the hairs move, then they will detect that type of touch. These are also rapidly adapting. But they are carried by little slower fibers, A delta fibers, maybe around 20 to 30 meters per second is the conduction velocity. Their sensation is also continuous but creeping. You just think about an insect moving or moving on your skins or in the hair. That feeling is the type of sensation they give. They are present in the hairy skin. Free nerve endings, these are located in the epidermis, and they are just in the interstitium or epidermal tissue. They carry the touch and pressure. These are slowly adapting. These are again A delta fibers. That means their threshold is high and their conduction velocity is low, but they carry the continuous information, and they are located everywhere and all over the skin and skin area. This is in brief about the receptors involved, mainly for touch and pressure and vibration. So that means here we have two receptors, the Meissner's corpuscles and Pacinian corpuscle for vibration sense. And for low frequency vibration, it is Meissner's corpuscles. For high frequency vibration, it is Pacinian corpuscles. Some of these receptors are involved in the proprioception. Going on to the next, what is the pathway of the posterior column sensations? Here I have drawn the spinal cord there. I have made two levels of spinal cord. The bottom one is the level of the spinal cord which is receiving inputs from the foot end, that is a toe. That receptor I have used is the Pacinian corpuscle. Entering into the spinal cord through the dorsal root ganglia. Then after entering into the spinal cord, it gives a collateral in the spinal lamina. This collateral may be necessary for modulating various reflexes, and then it ascends up medially. I have made the red line as a midline there, and ascends up, and these fibers are located in a bundle, what is called fasciculus gracilis. As from the sacral region, the lumbar regions, the newer fibers coming in, the sacral regions are pushed to the medial side. The lumbar then occupies the lateral portion. Then thoracic segments, whatever the receptors coming at the thoracic segment, they will come up laterally, then the lumbar segment, then the sacral segment. And as you come to the upper extremity, the cervical segments are coming up. The cervical segments are located medially. You can just see that the top one, I have taken it from the hand. That receptor, it is coming up, it is located medially. So there are two types of fasciculi made in the posterior column, or a group of fibers, bundle of fibers. One bundle located medially that carries the lower extremity sensation, that is fasciculus gracilis. One bundle which is located laterally in the posterior column, and that carries the sensations from the thoracocervical segments. All of these, that is fasciculus cuneatus. They ascend up, they relay in the nucleus. These nuclei are called accordingly nucleus gracilis or nucleus cuneatus. Nucleus gracilis receives the fibers from the posterior column located in the fasciculus gracilis, relay in the nucleus gracilis. The fibers traversing in the fasciculus cuneatus, they will relay in the nucleus cuneatus. Then they will decussate, cross over to the opposite side. While crossing over, the lateral fibers originating from the cuneate nucleus, that is the second order neurons, they move towards the medial side, and the fibers relayed in the gracilis nucleus, they relate relatively lateral. So that is the arrangement in the medial lemniscal bundle. Now they will ascend up from the medulla to the thalamus as a medial lemniscal pathway. In between, when they are ascending up, they give collaterals to various locations in the reticular system, that is the pontomedullary reticular system. They will give information to the reticular system that I have not shown here. And these bundles relay in the thalamus the area for the somatosensory modalities, that is the ventro-posterolateral nucleus of the thalamus. They will relay there. From the ventro-posterolateral nucleus of the thalamus, the fibers are then projected to the cerebral cortex, that is the parietal cortex there, that is the sensory cortex. This sensory cortex is represented, maybe I will go with the next slide. So this is the representation of the projection into the parietal cortex. I have made this figure. You see there is a central sulcus, then you have a lateral sulcus. Posterior to the central sulcus, there is what is called a parietal area just posterior to it, and this is known as a somatosensory area are a primary somatosensory area or known as S1. In this S1, the most interior is the, as I talk about homounculus later on, the most interior is the genitals, then the foot and the legs, and then comes the trunk. So that means the trunk is coming on the topmost or superiormost area of the cerebral cortex here, then followed by the hand, face and tongue. So in the order of this thing, that means head downwards. This is S1. These are S1 are classified as Brodmann's area 312. It may sound peculiar. It is not 312. It is area 3, area 1, area 2. So now area 3 is located in the one side of the gyrus, and the area 1 is on the top, area 2 is on the other side of the gyrus. You can just imagine that. So that is how it is nomenclatured. Area 3, 1, 2, 3 is divided into A and B areas because it is evolved area. There it is represented. From S1, these fibers give information to S2, that is the area located just above the lateral sulcus, that is called a sylvian fissure. You can just see that red area I have made, that is somatosensory area 2. Information from S1 and S2 have a meaning unless they discuss it with the somatosensory association area located in posterior parietal area, that is area 5 and 7. So that means first they are relayed into the S1, that is area 312, primary sensory area. That relay will talk to the sensory area 2, that is S2. So from there S1 and S2 together, or S1 gives information there, S2 gives information there, both things are processed in the somatosensory association area. Now from the somatosensory association area, the meaning or interpretation or a detailing or the attribution of the sensory modality is performed. Now you see how they are represented in the cerebral cortex. As I was mentioning, the innermost, that is in the medial side, you have the genitalia. There is quite a good representation, you can just see there. Then after that the toes are coming up, then comes the foot, the leg has a little that bend of that inner to the outer top superior portion. Then comes hip have a very little representation, trunk has a very little representation, you can see just their bars, and then neck and head. So suddenly from the trunk, neck and head coming up. After that you have a shoulder coming, shoulder representation, the arm representation, elbow representation, the forearm. Now the wrist is becoming a little larger, hands become large. Each finger is represented tremendously because the Homo sapiens, that is the human beings, use their hands for the number of sensory purposes. So now you have that all the fingers are being represented with a large amount of a sensory modality. You can just see the distribution of each finger. So that means the hand and the finger, they occupy a very good area there. Then comes the eyes, the nose, the face, then upper lip. You see the lower lip, the enormous amount of representation. The lips as such, they have a greater representation, followed by teeth, gums and jaw. Now tongue has a very large representation because Tongue here subserves another important function of the spatial sense, that is a gustatory sensation. For that reason, tongue has been represented largely here. Then comes the viscera, the pharynx, and the intra-abdominal structures. They are just they get a small representation. So thus there is no linearity in the distribution. There is a disproportionate representation. This disproportionate representation is according to the functional significance of each part. If we will construct a caricature, you will see a monster as you have seen it here, with a large face, very big eyes and a big nose and a very thick lips, very large and thick lips, and a protruded tongue, a very great representation of the tongue. And practically the ears have become large. Then the neck is practically not there. That caricature looks emaciated, maybe even little lesser than this. And you see the hands are coming up, and if you look at the hand, they become very large. The fingers, each finger is bigger and bigger. And coming back downwards, the entire trunk is very small, maybe smaller than what has been depicted here in this picture. You see the genitalia larger proportionately, and the lower limbs still smaller. So though they may be still smaller, and that is how the caricature, if we can reconstruct the caricature from the homounculus, that is how it looks like. The sensation is arrived in the cerebral cortex. Now the issue is how it is processed. To brief, the area located in the parietal cortex posterior to the central sulcus where posterior column sensations are relayed. This area is known as a primary sensory area, or S1, or areas 312, already I have described. The representation of various parts is shown in the homounculus and is proportionately located according to the functional significance or functional importance. I have already mentioned about it. Because the cortex is having 6 layers. Layer 4 is a layer which receives sensory input, and the thalamocortical projections relay on the layer 4 of the primary sensory cortex. And from these layer 4, maybe when we study in detail, you will know how it communicates with the layer 2 and the layer 3 and the layer 5. Each one of them, it gives a dendritic arborizations to the, because this layer 4 is inner area, then there are 3 superior layers of which it gives a dendritic arborizations. So then there are axon collaterals in the layer 5, that is the pyramidal cell layer, and the 6th physiomotor cell layer. So they are also all these things distributed. Already you have seen the localization of the sensory sensation is shown. Suppose if I place a microelectrode on the cerebral cortex or the parietal cortex and stimulate it, and the person during the neurosurgical operations, person feels the sensation of a particular modality it has received. So that means each of these receptors are localized, the sensations are also localized. It will tell that he has a touch, he has a brush, he has a vibration, or whatever he will tell all those things. The S1 area, that gives outputs to the somatosensory area 2, as well as it also gives output to somatosensory association area in the posterior parietal cortex as shown for further processing. Hence, the lesions of the primary sensory area lead to loss of appreciation of the external sensations. Also, the conscious proprioceptive sensations from the opposite half of the body, because they're crossing over in the medulla. So that means if there is any lesions here on the right cerebral sensory cortex, there will be loss in the left side of the body. What are the functions? Because if you are looking at in S1, there is a localization of the sensation. S1 receives the input. S1 try to understand the inputs in association with S2. The S2, that is secondary sensory area, is located just above the upper lip of the sylvian fissure or the lateral sulcus that I have already shown. The representation of the S1 or S2 is face area is located most anteriorly and the leg area is most posteriorly. In studies, it has been shown that S2 alone cannot understand, if there are no inputs from S1, will not process any sensory modality. So that means it requires the input from S1 and then it refines or it gives attributes, further attributes of the sensation. That means it acts as a helper to S1. So here in S2, it is represented bilaterally on both sides of the cerebral cortex. The output from S2 will go to posterior parietal area, that is the somatosensory association area 5 and 7. Also, the S2 will communicate to the limbic association area, especially the hippocampus. Now these two association areas, one the somatosensory association area and the limbic association area, they put them together, they give several attributes of the sensory modality. S2 basically concerned with the tactile discrimination, the spatial location of the receptors and other information of objects stored in the memory, because recall memory, because it is connected to the limbic association area, it will try to bring in that. Say for example a touch, other class I was talking about a touch of a mother. That means that memory is stored in the memory, it is stored, this is the type of touch. So then that type information is brought through the hippocampus here to the S2 and gives attributes for that. So in the middle of the night somebody comes and touches you on your back without you seeing him, you suddenly get scared. So these are the type of sensations. So that is a stranger sensation that you can detect. Moving on, what are the functions of the posterior parietal area? The posterior parietal area is a somatosensory area, somatosensory association area. That means it associates all sensory modalities here. Both of them, they are getting associated. So this represents the area 5 and 7 of the Brodmann, categorized by the Brodmann. It is situated superior parietal lobe posterior to S1. I have shown it. This area has number of cluster of neurons which would understand shape, which would understand, which will be triggered by size, which will be triggered by the texture or roughness, and which will be triggered by the direction or orientation or direction of motion or angulation or many attributes of the touch, or the pressure, or the vibration. Other details of the objects, further other details of the objects in reference to other sensory modes are analyzed and decoded. So that means this posterior parietal area gives the object a shape, gives the object a size, gives the object a roughness, what is the nature, and also how that felt, or how that object is felt. So then it gives even it will try to know what is its weight. Say for example, blindly I am touching an object. Suppose if it is a book or whatever, then I will say, I will just have a rough approximate of that book size and this thing. Or even if I am just trying to pick up a more mobile telephone, and I will know that what is the, even if by touch I will say that what is the probable weight of the thing. So like that, these textures are analyzed with the association areas. Further, this association area communicates with the visual association area, communicates with the auditory association area, communicates with the limbic association area, also with the motor association areas. So accordingly, by just touching, a imagery, visual imagery can be obtained, or the person will have a visual imagery of the object he has touched. Or he can imagine what happens if that what type of sound that object may produce if it falls. That is an auditory association area. Also, suppose it's a knife. If it is a knife, object is a knife, then he can associate the knife with the emotion associated with the knife, whether it is harmful or not harmful, and what are the things. Here I'd like to give an example. Suppose if I touch something like a rope-like structure in the night, and it is soft and slimy, suddenly what is coming to your mind? The coming to your mind is a snake. Now, if that is a snake, then what are the emotional components associated with a snake? That means you get scared. You immediately throw it. Then you will just be restless. So that is the type of association, because a visual, auditory and limbic association areas try to give a meaning to the object. The somatosensory area gives the object properties, attributes of the object, and here they give meaning to the object. This area, therefore, the posterior parietal area is essential for what is called a stereognosis. That is the ability of an individual to recognize the objects placed in his or her hand when blinded. I have already explained this thing in the previous class. That means a commonly used objects like a pencil, pen, I can immediately recall and say that this is what it is. That is a stereognosis. To review here, association area gives the attributes. The association area in association with the other association areas gives a meaning and the existence of the individual. Now I am just showing the the picture of the brain where you see the primary somatic, what is it? That is the association area, that is the central sulcus there. So then in front of the central sulcus, anterior is the primary motor area and posterior is the primary somatic area. On the top of this thing, secondary somatic area. Here you have in the angle, just above the primary auditory area, you have S2 here, just above the primary area, that is the sylvian or the lateral sulcus, where it is ascending up. In that corner you have S2. So then we have the association area. This association area, that's only parietal association area, it's not enough. Parieto-occipito-temporal association area. This parieto-occipito-temporal association area combines the three modalities, that is a sensory modality, the visual modality and the auditory modality. All of them put together, they are sensed here. That is the association area. On this side you have the occipital cortex, that is a primary visual. On the other side you have the frontal cortex, that is the frontal association area. So then supplementary motor area and the premotor area are located, and you have this in the lower part, that is a limbic association area, where hippocampus and all the memory linked issues are there. Just to give you a brief idea about how the sensory modalities are going through. Now coming back, what are the various clinical abnormalities associated with this posterior column sensation? There is what is called a condition, subacute combined degeneration. The subacute combined degeneration is seen in pernicious anemia and nutritional vitamin B12 deficiency anemia. And in these, the vitamin B12 is necessary for the myelin synthesis. In pernicious anemia, there is a deficiency of the intrinsic factor which is necessary for the B12 absorption. Whether it is the deficiency of the intrinsic factor secreted from the stomach, or because of the extrinsic factor, that is a nutritional vitamin B12, B12 is absent. If B12 is absent, there is no synthesis of myelin, because of B12 is also necessary for the normoblastic reaction in the hemopoiesis. In the erythropoiesis, B12 is necessary for normoblastic erythropoiesis. So in the absence of B12, there is a megaloblastic erythropoiesis. That is why you have the macrocytic anemia. The large cells are produced. That means erythropoiesis is not in a normal phase. But however, coming back, because the myelins are myelin synthesis is hampered, then the fibers the myelinated fibers are not being myelinated. They will lose their myelination, and hence you will have an abnormality. Most of the sensations carried by the posterior column are through the myelinated fibers. Since myelin is affected, so they will lose. Hence you may find the loss of sensation, the touch vibration in vitamin B12 deficiency. This condition is called subacute combined degeneration. Maybe you will be studying this thing in clinical side in detail. Then comes a degenerating demyelinating disorders. So that means they will affect this myelination. And thirdly, I have just given an example of nowadays the syphilis do not exist because of the antibiotics. The previously in 1950s or earlier, before the discovery of the penicillin. So syphilis is going into secondary and tertiary stages. This is tapes dorsalis is a tertiary stage of the syphilis in which that would affect the large diameter sensory fibers. Hence, all these conditions affect the posterior column sensation. Because the pain and thermal sensations are carried by the unmyelinated fibers or thinly myelinated fibers, they preserve the pain and thermal sensations. That's one aspect. Another aspect I am talking about, suppose you are sleeping. When you are sleeping, you have a habit of placing the hand underneath your head. Head is a hard object, and you may just sleep for hours together, maybe 6 to 8 hours you are sleeping, and when you wake up in the morning you are not able to move your hand, or you are not feeling any sensation in the hand. And this type of things are seen with the alcoholics, wherein they lose sense. They lose their, after the intoxication, they lose their consciousness and they just sleep as they are, and this is known as a Saturday night paralysis. Saturday night means Saturday night boozing and then going into unconscious stage or a sleepful stage, and that type. This is one. The second, this is also called a crush paralysis. Crush means you are trying to take help of those walking aids in which the axilla you are placing it, and there is a pressure and that. So anything that pressure, that have a pressure on the nerve or a nerve trunk, that because of that there is a compression or external force that will stop the sensations. One important aspect, the large diameter fibers are sensitive to pressure, external pressure on the large diameter pressure. This thing they will stop conducting. Whereas the small diameter fibers are not affected. Small diameter fibers are sensitive to local anesthetics. So the sensations carried by the large diameter fibers, that is, they are affected, that sensation is lost, and the posterior column sensations are through the large diameter fibers, that is A beta fibers, they are myelinated. Hence, there is a reversible loss of sensations carried by the posterior column. The vibration, touch, pressure is lost. Even the proprioception, the position is also, he is not able to make it the position properly. So that is called Saturday night paralysis. Lesions of primary sensory area are difficult to produce because you have to produce a large area of destruction. But anyway, the fibers going, some of the fibers, they can be lost, but what is the result? You will lose the fine touch, vibration, and tactile discrimination and tactile localization on the opposite side of the body. These sensations are lost because of the lesions in the primary sensory area, and to produce that, a very large area of the sensory cortex to be involved. There is another term called astereognosis. This is the loss of stereognosis, or also it is known as a tactile agnosia or astereognosis. Inability to recognize or identify the common object by its feel. So it happens if you lose that somatosensory association area 5 and 7, and also anywhere in the path. If the S1 is not there, that is not reaching, you will have a stereognosis. And you have, say for example, you have a tactile localization, but you have a stereognosis. In that way, tactile is intact and the stereognosis is there, lack of the stereognosis, then there is a particular somatosensory area is affected. Like that you can identify. So you have a tactile localization but have an inability to have a discrimination. You can identify the type of lesion because discrimination is done by the S2. So that means these are particular areas may be involved. There is another condition, idiomotor apraxia. Again, this is the lesion produced in the superior parietal lobe, especially that somatosensory area 5 and 7. Loss of ability to produce purposeful skilled movements. I mentioned these association areas talk to each other. Association area, somatosensory association area talks to visual association area, talks to auditory association area, talk to limbic association area, talk to the motor association area. Here it is the loss of ability to produce purposeful skilled movement because the motor association is lost, that is not sending the information, and that will movements as a result of brain pathology not caused by weakness or paralysis or lack of coordination or sensory loss. It's nothing to do with the motor cortex, it is something to do with the somatosensory area. You can identify like this. So now I've taken most of these things from the guidance textbook and the Genong's textbook. Please, you can refer them. In the next class or in the next lecture, we will continue with the proprioceptive sensations, pathway, processing.